Hello, I'm Dr. Donald Jurovich. I'm a University of North Dakota professor of geriatrics. The topic today is age-friendly healthcare with a focus on provider leadership. So the question arises whether healthcare providers in any manner can be the drivers of quality improvement. A lot of this is based upon a conceptual framework of Plan, Do, Study, Act cycles of change. In the context of age-friendly healthcare, we can see the different elements of quality improvement. It firstly helps transform clinical encounters from not only asking what is the matter with the older adult patient, but it also establishes what matters most to them. The project also helps revise clinical information, much of which we're gathering already, and it puts it into a one-moment glance in the electronic medical record so that the providers across the continuum of healthcare can be on the same page for what the individual wants and what their risks are in the geriatric domains of the 4Ms. And then finally, the Quality Improvement Project helps us understand the fidelity of the project and whether we're consistently acting on our assessments in a meaningful way. I'll give you an example. If somebody screened positive for a PHQ-9 of, let's say, a score of 9, is there an action plan associated with that unresolved depression? So you might ask what motivates providers to pursue quality improvement, and there might be a lot of answers to that. Certainly incentive pay might drive their interest, maybe disincentive pay. Career advancement is important. Professional development is important. And then ultimately, I think all healthcare professionals generally have some altruistic features and they somewhat have a DNA for wanting to see things better. We like to refer to collaborative champions in quality improvement. These are people at the local level who help drive projects and improvement in clinical outcomes. They help raise awareness. Oftentimes they're the folks that are on top of the medical literature and come up with new ideas. There are some significant barriers to quality improvement. We can see this bell-shaped curve that there's the middle of the road folks that are plus minus as to whether adopting something new versus the early adopters or innovators that are on board quite rapidly. And at the other end of the bookend here are the laggards, or what I call the refuseniks, who are the no ways, no how type people. There are a spectrum of barriers that need to be addressed and often attempts made to overcome these. So for example, the lack of data support might be an important question. Not having enough time to conduct quality improvement. There might be underlying frustration with the unengaged. Again, I call these the refuseniks. Perhaps staff turnover. Maybe there might be competing initiatives. So, people are looking at the hemoglobin A1Cs or the cancer screening methodologies, and are we meeting metrics there versus are we meeting the 4M metrics? And really, they should be integrated with one another rather than competing. As we see in this Picasso painting of a discombobulated bullfight, we can remind ourselves of additional barriers where you get folks that have low enthusiasm for quality improvement and they don't see it as a priority, or they may complain it's more work. All which are valid concerns, but need to be addressed in the process of those that really want to create a culture of improvement. So quality improvements start at different levels. They could be at the individual or they could be at the health systems level. So it's kind of a bottom-up, top-down approach. And typically you want to cultivate individual approaches towards quality improvement because it's the people in the trenches that really make the difference. So they see a problem or they want to test a new idea. And this actually came up in one of the hospitalists who said, I came across this age-friendly thing. I want to try it on the unit. And it happened, and it really produced some good results. The goals of quality improvement include the desire to rapidly translate clinical research into clinical practice. You also want to, at times, reframe clinical logistics or the workflow to enhance services, as well as make them more efficient, perhaps. And then finally, you want to ask, how are the things that we're doing making a difference in people's lives? A lot of this is driven by data. And so as an example, you might want to frame the question through, if you happen to observe that advanced care plans are underrepresented in the medical chart, or people aren't not really doing their advanced care plans. So you might have an opportunity to implement a project under What Matters from the 4 M's and see the advanced care planning documentation increase by a certain percentage. Oftentimes, patient registries help identify and focus the projects. And so, for example, if you're interested in improving caregiver training amongst patients who have cognitive impairment, you're going to want to know who all the cognitively impaired patients are in your clinic, and then one by one, making sure that they've had referrals for caregiver training. In the instance of using the Alzheimer's Association as a referral base would be a good example. Projects are supposed to be time limited. And typically they're around 6 months. They're supposed to intentionally be short cycles of change, and they are predicated on the concept of all teach, all learn. So you have to pretty much kind of understand why we're doing the change, what's the evidence for it, and how we're going to make those changes occur as applied within our specific setting. After these changes are starting to be implemented, you want to share the progress and see what's working and what maybe is not working. And that leads to a decision as to whether to further adopt the changes or not. And if you do adopt them, that they do so through a sustainable manner, and that they spread the change to, for instance, other clinics or clinical operations. Again, just to emphasize that you want to start small scale, utilize the framework of Plan, Do, Study, Act cycles, where you carry out the test and you review the data as you're applying the change, and then you come to some conclusion as to whether you want to move it forward or not. So here's a good example of using the age-friendly metrics of the 4 M's. So we want to see through our mobility plans, we want to see a decrease in falls over time. We want to see an increase in the advanced care planning. We want to see a decrease in polypharmacy, and we want to see an increase in caregiver training. These are all aspirational goals, and again, we won't know unless we get the data as to how well we're doing this. And these all center around what we call the MIPS, and you can see here the different categories of the Merit Incentive Payment System, and these are reported out to CMS and insurance agencies. These are standard measurements of many measurements that might be used. And so one of them is caregiver training, the percent of patients with dementia that have had their caregiver trained in a evidence-based training program. We want to look at the number of non-cancer patients that are using opioids for chronic misuse or potential of misuse. We want to look at the percentage of patients with documented advanced care plans, percent of patients with that have been evaluated for fall risk, and finally, the fifth MIP of looking at the number of patients that have been addressed with unsafe medications. So I'd like to finally comment on the transition from quality improvement to sustainability, and a lot of that is built upon relationship building. It's important to get all team members involved. It's important to provide allocated time for the quality improvement projects. And then I think really one of the big things is the rotten apple in the barrel there, where you have to really address the skeptics and the passivity that sometimes accompanies quality improvement projects. Also, as at the individual level, it's encouraged to have a vetting of their ideas and to have a forum through meetings to express what they want to accomplish with a particular idea. It's also important to get everybody involved, and so responsibility really begets motivation. You want to also encourage feedback about the proposed changes, and so again, that's a form of communication that might occur through weekly meetings, reviews, reflections, and commentaries. It's important for those involved in quality improvement to monitor the pace, because if things go along too slowly, it just may wither on the vine. You also want to focus on results and continually assess these results on a 30-day basis, and so data collection should be on a regular and real-time basis. So if you look to mature the quality improvement project, you have to look ahead to the future and assess how well you've been doing. And so some of it may be, well, we've implemented this particular age-friendly program. Are we still doing the 4Ms as we said we're going to be doing them? And so sometimes you have to look back and do fidelity measurements as to how well you're applying the 4Ms, or it may be, yeah, we're doing all the assessments, but only half the time we're creating action plans, and so you need to, strengthen the action plan component of the age-friendly framework. Later, you might consider a intervention program to prevent frailty, and so how are you going to identify pre-frail individuals and then create a program to prevent them from becoming frail? Some of the outcomes that we're looking down the road are, as mentioned in those graphs, fall reduction, changes in functional and cognitive trajectories, so that rather than a steady decline, that maybe we just level them off, and so that they're at a higher functional and cognitive level than we would have expected with usual care, as opposed to our newly enhanced quality improvement care. So just as a reminder, age-friendly has been proven in the literature to work in multiple different levels. Locally, we can see that the application of geriatric principles of care in the 4Ms helps reduce hospital length of stay, as well as hospital recidivism. So it really does work. To summarize, I think we feel somewhat like the Calder statue here of having to bend over backwards to affect quality improvement, but we have to be diligent and persistent, and we really do have to serve as what I call QI champions. Certainly within the context of Sanford Healthcare, we are here for good. And so the quality improvement aligns nicely with that motto and vision. And in considering quality improvement, we want to create and vet our projects and launch them in small manners through plan, do, study, act cycles of change. And we want to be mindful of educating through all teach, all learn concepts, sharing the medical literature, sharing best practices, and actually creative ideas to help make things better. We want to gather and evaluate the data to help inform the project moving forward. And then finally, as we complete these projects, we want to share and disseminate the best practices and help move the whole operation from patient-centered care to population health metrics. So thank you for your attention. I really appreciate your involvement in the Age-Friendly project, and I look forward to our strengthening older adult healthcare.